Hello.
Good evening, ladies and gentlemen. Today, our monthly clinical neonatal update will be done by Dr. Sathika Amarasekara. She is a consultant neonate. After her local training, she has served in teaching hospital Jaffna and Mahamodara before departure to her foreign training in Australia. Currently, she is working as registrar in King Edward Memorial Hospital and Perth Children's Hospital. Today, the topic will be learning from overseas training. I would kindly invite Dr. Sathika Amarasekara to deliver your lecture.
Jitma, can I interrupt
Yes,
a bit? Hello? Do
Yes,
we have a sponsor today?
We don't have a sponsor today.
Right, okay, right, okay.
Can we start the
Yeah,
lecture
yeah,
now?
okay, go ahead.
Okay.
Okay, Sathika, you can start your lecture now.
Okay, thank you. Thank you very much, Dr. Jitma, for your kind introduction. Good evening to you all. Today, I'm going to talk about things we can learn from our overseas training to improve our neonatal care. Can all of you see my slides?
Yes, we can see.
Okay. During this presentation, I'm going to concentrate mainly on care of extreme preterm neonates, where I'm going to focus more on prevention of hypothermia, skin care of neonates, and prevention of late onset sepsis and early onset sepsis calculators, central venous access device model, and neonatal pain management, and how to ensure medication safety and palliative care in neonatal practice. Care of extreme preterm neonates. When it comes to our setup, the two main challenges we face are hypothermia and late onset sepsis. So first of all, we see what measures we can take to prevent hypothermia. Here, at delivery room, we use this NeoHelp special plastic suit and NeoWrap. This is a simple plastic polythene sheet. The NeoHelp is especially for babies less than 32 weeks of gestation. This comes in two different sizes for preterm babies. As you can see in this picture, there is a part which covers the baby's head, and there is an opening in the middle, and there is a small cushion pad on the back to support the baby's back. This NeoHelp at the delivery room, we do all the environmental modifications, and then we set the resuscitator heater output to 100%. And then we place 2-3 layers of thick blanket to warm up. And on top of these blankets, we keep this NeoHelp. And then we make a small hole in the right upper corner so that we can take the baby's right hand out to attach the saturation probe. This is how we can see when we place the baby inside this suit. When the baby is born, immediately we transfer the baby to this special polythene suit, and this is how it appears when we transfer the baby inside this suit. We take the right hand out to attach the saturation probe. As we all know, in preterm babies, they don't need extensive resuscitation. All what they need is stabilization at birth. Once we stabilize the baby, once the airway is ensured and everything is ready, then we wrap the baby with the thick blanket which we place under the baby. On top of this plastic suit. And then we put a hat and then unplug the resistor and transfer the baby to nursery. At nursery, like we practice in Sri Lanka, we transfer the baby immediately to the pre-warmed incubator. And once the airway is ensured again, next step is to get the IV access. Before the ambulance insertion, what we first do is get the IV cannula inserted. There, again, we have to open the incubator hand ports. In that situation also, there is a chance that baby become hypothermic. There, what we do is we have plastic drapes, just simple plastic sheets which comes in sterile packs. We cover the baby whenever we do procedures which requires the incubator door open for prolonged period. And also, when we do ambulance insertion, umbilical venous catheters, arterial lines, PICC line insertion, and head scan, echocardiography, during all these procedures, we use these plastic drapes. And for sterile procedures like ambulance insertion, there are special plastic drapes comes in sterile packets. Further care, so first day we get the head scan, and second day we do head echocardiography for extreme preterm neonates. And then bedside nurses do not allow us to handle the baby unless there is any concern. And other important thing is here we get the umbilical arterial line and umbilical venous catheters at the beginning. The purpose of this umbilical arterial line is for blood sampling and blood pressure monitoring, especially this very preterm sick babies who are having some pulmonary hypertension. And other important thing is we can do blood sampling without venipunctures and heel pricks for blood gases. We can use this umbilical arterial line until the baby is stabilized within first couple of days. Then umbilical venous line, as we usual, we keep it for 5 to 7 days for total parenteral nutrition. And if we can't grade up feed faster, then we consider getting a PICC line insertion. And cluster care is this routine thing we do 3 to 6 hourly. Unless there is any concern, doctors do not examine baby every day. And there's once a week, but however, once a week, every doctor should examine the baby. Once this arterial line comes out and all the blood sampling is done by heel prick, we don't do venipunctures routinely unless it is for coagulation profile or blood culture. All the bloods, full blood picture, CRP and electrolytes, all the tests, all the blood sampling is done by heel prick sampling. Next, see what measures we take for preterm skin care. The preterm skin, as we all know, preterm skin is very fragile and immature. They have very less amount of subcutaneous fat, therefore they have increased transepidermal water loss. Their thermoregulation is ineffective, that is why they become easily hypothermic. They have increased absorption of topical agents, which we apply betadine, surgical fluid. There's a high chance of absorption of these chemical agents. And also they are having higher risk of epidermal stripping with the plasters and also with chemical agents. Alcohol-based cleaning products like surgical spirit are highly irritant for this preterm skin. If the skin is damaged by any chance, they are at higher risk of infection, delayed healing, and skin maturation. So what we can do, how we can improve the skin care of these babies. One thing is when the baby is admitted to nursery, we set the humidity of the incubator to at about 85%. We maintain this humidity during the first week of life. Then gradually we start reducing the humidity by 5% from day 7 to day 14. And at the same time, we need to make sure we don't leave any moisture after the cares and procedures, because if you leave the moisture, that can cause maceration of the preterm skin very easily. Next practice is for skin care is application of coconut oil. This is a widely accepted practice in some Asian countries, because in countries like ours, coconut oil is available widely. Now in countries like here also, they extensively started using coconut oil for preterm skin care, because coconut oil is known to improve the preterm skin integrity and reduce the chances of infection. There are a lot of randomized controlled trials for using coconut oil to improve the preterm skin integrity without adverse effects. This is one of the recent meta-analysis on use of coconut oils for preterm skin. Topical coconut oil application to the skin may be beneficial in preterm neonates, but the quality of evidence is low to moderate. However, we use coconut oil for extreme preterm babies 4 times a day, and continue it until the day baby is going home, or until they come to term gestation. The other practice is application of chlorhexidine 1% lotion once in every 2 days to prevent staphylococcal infection. Whenever nurses do the cares, they apply this chlorhexidine lotion and leave it for 10 minutes and then wipe it with cotton wools. This is to prevent staphylococcal infection. Then we have skin condition assessment score and pressure injury assessment score. The goal is to identify the babies who are having high risk of skin dryness, erythema, and those identify babies who are more prone to develop pressure injuries due to various reasons. This skin condition assessment score called neonatal skin condition score. Here we assess dryness, erythema, and breakdown of the skin. And depending on the skin condition, one baby can get a score from 3 to 9. Perfect score is 3, worst score is 9. So what can we do if there's any concerns regarding the skin? If the bedside nurse found that the baby's skin is excessively dry, in addition to the coconut oil application, we use this Dermis cream and ointment. This is Dermis cream is contain white and soft liquid paraffin, and it shows no concerns regarding systemic absorption. This is something we use. And if by any chance, if the skin is breached, then we use this Mepitel dressing. This is not a neonate actually. These dressings are available in burn wards, and if there's a skin breach, always we can ask for opinion from other specialties like plastic team and dermatology team. And the other thing we can do is to apply this Mepitel dressing. The other thing which made our life easy here is use of this adhesive removing tape, adhesive removers to remove taping from endotracheal tubes and cannulation. And by using these adhesive removers, reduces the skin damage, skin stripping from the underlying dermis. This is the pressure injury score we use here. I'm not going to describe all these details in this chart. The important facts are there are risk factors for pressure injury, like gestation age less than 32 weeks, and those who are having vascular compromise, like babies who are with hypoxic ischemic encephalopathy, and the babies who are on inotropes due to hypotension, and those who are having neurological impairment, causing immobility, and those who are on muscle relaxation and sedation. Babies with severe sepsis are at higher risk of developing pressure injury. And at the same time, there are various monitoring devices which can cause pressure injuries like endotracheal tube, nasal CPAP prongs, high flow prongs, and transcutaneous monitoring, saturation probes, ECG leads, temperature probes, all of these. And these cannula splints and IV, even cannula hub can cause pressure injuries, which we all experience some kind of pressure injury during our practice. So in the presence of these risk factors, and if the baby, depending on the baby's mobility, one baby can get a score from 0 to 35. The score 35 is the worst score. Then this is how we assess the risk of pressure injury. If the score is 0, then they are not at risk of any pressure damage. Then all what we have to do is continue to assess daily and every time if the condition is changed. If the score is between 10 to 15, then we need to inspect the skin twice a day, and we need to relieve the pressure by repositioning the baby at least 2 to 4 hourly. If they are at higher risk of pressure injury, we need more frequent inspection and repositioning. We need to change the equipment every 2 to 4 hours. If they are at very high risk of pressure injuries, frequent skin inspection is required, and we need to move or turn the baby if possible. And equipment, we need to ensure the baby, any equipment, so devices not pressing on the baby's skin. And apart from that, there are various things help to prevent pressure injury, like sheepskin, air mattresses, gel mattresses, and gel wedges. So many other things are there to prevent pressure injury in these babies. This is another thing we can use for prevention of nasal injury. Here we use these Hudson prongs for CPAP, and these babies, especially extreme preterm babies, are going to stay in the NICU with CPAP for ages, and they are at higher risk of developing nasal septum damage. So what we do is the Comfeel is sterile, some form of sterile dressing. It comes like this, and we take a small piece of that and then attach to the baby's nose like this, and on the cheeks to prevent the pressure injury from the prongs and this bar here. And also every day the nurses do this hat release during their shifts to prevent pressure injuries. Then we have this fancy ET tube holder called NeoBar. This is very easy to use, for babies. And using this NeoBar, we don't have to use these nasty tapes on the face, which cause damage to the baby's skin. This NeoBar, use of this NeoBar reduces the unplanned extubations or tube dislodgement, and it is comfortable for the baby as well. As you can see here, this ET tube we fix to this bar here, and only taping we use is to attach this ET tube to this bar. And it is, again, it's very easy to adjust the ET tube whenever it's required. It is something to consider in future once we have enough resources. Next, move into the prevention of sepsis. Incidence of late onset sepsis is very low in the unit I work here. There are about 25 cases per whole year, and admissions are around 2,000 per year. Antibiotics use is extremely low, and hand hygiene is strictly observed by the nurses, and we are not allowed to touch the baby without proper hand hygiene. and minimal handling is the other important thing. And skin pricks are also try to minimize the skin pricks, which is one other source of infection. One other important thing I would like to mention here is minimal sharing of consumable between patients. In our setup, the problem is we have one big saline bottle and betadine bottle for the whole unit, and one big surgical spirit bottle as well. So what happens is the different nurses looking after different babies come and touch these bottles, and there's a high chance by doing so, there's a high chance of cross-infection within the unit. Therefore, we try to reduce this practice, which cause infection. What we can do is here, actually, we have 10 ml saline vials. We use only for one baby, and also saline syringes. With the available resources, I think we can discuss with the pharmacy or dispensary to make small bottle out of this big bottle, so that we can use one bottle for one baby. And using one scissor is not a difficult task. And also I think we can use one plaster for one baby. Then we have this early onset sepsis calculators, which is one very good tool which prevent unnecessary use of empirical antibiotics for early onset sepsis. This sepsis calculator we use especially babies more than 35 weeks of gestation. It's a very easy calculator which can, if you have internet, computer or smartphone with internet connection, any healthcare professionals who is involved in neonatal care can use this sepsis calculator. Here, the person who is attending the delivery, midwife or the doctor, has to assess the risk of early onset sepsis. You have to enter the incidence of early onset sepsis. It is 0.4 per 1,000 live births in for Caucasians, gestational age, and highest maternal temperature, duration of rupture of membrane, maternal group B streptococcus status. And then next thing is to enter is whether mom is treated with antibiotics for chorea pneumonitis. When you enter all this data, it will give you a value. That is the risk of early onset sepsis. Depending on the risk, the value, it again gives you the recommendation for further management. If the risk is very high, then we need to strongly consider starting antibiotics, and baby needs to go to NICU for close monitoring. This is one of the systematic review and meta-analysis on use of early onset sepsis calculator. It says that use of early onset sepsis calculator is associated with substantial reduction in the use of empirical antibiotics for suspected early onset sepsis. However, data regarding safety of the use of early onset sepsis calculator is limited, but shows no indication of inferiority compared with conventional management strategies. This is a very easy tool, and I don't think it needs a lot of money or technology to use this early onset sepsis calculator. When it comes to the sepsis, the other main problem we commonly encounter is ventilator-associated pneumonia. Web bundles, but there's a protocol on prevention of ventilator-associated pneumonia. These are some of the measures which we can implement to prevent, to minimize ventilator-associated pneumonia. One thing is elevation of head end of the bed. We know there are, when the baby is in supine position, there's a chance of microaspiration of the stomach content, which is ventilator-associated pneumonia. So all the babies who are stable should nurse in head and should nurse by elevation of the head end of the bed by 15 to 30 degrees. Next thing is oropharyngeal suctioning. Oropharyngeal suction, this is not the endotracheal tube suctioning. Ventilated babies, they have increased accumulation of secretions in the subglottic area, and these secretions rapidly colonize with the bacteria. So whenever we do repositioning and infant cares, intubation, re-intubation, extubation, there's a very high chance of aspiration. Bacteria colonize the secretions in the subglottic area. Therefore, we should make sure we suck oropharynx before we do all these procedures like endotracheal tube restrapping, infant cares, repositioning, extubation, and re-intubation. ETA suctioning, this is one other practice we routinely do in our setup, but ETA tube suctioning should not be done as a routine basis, because and also we should discourage using normal saline. There are no evidence for using normal saline. In fact, it can cause adverse effects such as hypoxia and dislodgement of bacteria colonies. The other problem in our setup is we don't have closed suctioning system or inline suctioning. එතකොට අපිට වෙන්නේ හැම වෙලේම ET tube එක ventilator එකෙන් disconnect කරන්න වෙනවා. These babies have very stiff lung, and whenever the moment you disconnect the baby from the ventilator, these stiff lungs again go back to the atelectatic status, and then it takes some time to improve this, recruit the lung. Therefore, we should only consider endotracheal tube suctioning if it is really necessary only, because situations like if the blood gas shows respiratory acidosis, and if you think the baby is, and if the baby is desaturating, and if you feel the air entry is reduced and chest expansion is reduced, then only you should consider endotracheal tube suctioning. Most importantly, we need to practice hand hygiene before and after handling this respiratory equipment, and it is very, very important. These are the suction catheters we use for oropharyngeal suctioning. As you can see in this picture, the suction catheters have blunt end, and there's because of that, the chances of mucosal damage is very low. And these suction catheters should be changed every day. Every day, the suction catheters should be changed. Then I'm going to talk about the central venous access device bundle. This include caring for umbilical catheters, central venous catheters, and PICC lines. This central venous access device bundle, or CVADS bundle, has insertion bundle and maintenance bundle and removal. I'm not going to talk about this insertion bundle. It describes how we do the procedure under strict aseptic conditions. The maintenance is the problem we are facing in our setup because of the line-related sepsis and line occlusion. The CVADS maintenance bundle, before you touch the bundle, you need to practice the hand hygiene, and strict hand hygiene is essential. And here the nurses and medical staff who are involved in the care of babies with central lines, online training should be completed. And every time when you care for a baby, you need to question, you need to assess whether this line is working perfectly. And during each ward round, we need to review the requirement of this central line. And during each shift, we need to assess the dressing and the site of the line catheter insertion for redness erythema and leak and swelling of the limb. These things should be documented in the monitoring chart. The next thing is whenever you connect infusions or when you give in antibiotics, the needle-free ports is these parts should be cleaned. This is the cleaning solution we use here. At least we should use some kind of cleaning solution before you touch this part, before you give antibiotics or connect infusion. It's very, very important to prevent line-related sepsis. The most importantly, the main problem we face in our setup is frequent line occlusion. So this is how we should ensure patency of this PICC lines and ambulines. Whenever we insert the line, immediately we should start heparinized saline, heparin 0.5 unit per ml heparin saline until we get the X-ray done to assess the line position. And after that, once you confirm the line position, we should not disconnect the line frequently for antibiotics and to connect various infusions. I know we don't have double lumen umbilical catheters and PICC lines. We have single lumen catheters. For that, I would like to suggest using this IV extension set. So as you can see in this picture, this IV extension set has 3 ports, and then you can use multiple infusions through these ports, and you can keep one side free for antibiotics if we have to give. Whenever you change the infusion set, aseptic non-touch technique should be followed, and infusion pumps, we should set the pressure limit. If the pressure is going up, then we need to take some action. Frequency of the infusion set, we change every 96 hours, every 3 days. Once in every 3 days, we change the infusion set. And next, I would like to mention something about a peripheral cannula insertion and management, because it is one of the most frequent procedure in NICU. There is a cannula insertion flow chart in our unit. The purpose of this flow chart is to prevent multiple attempts on cannulation, because as we all know, whenever we damage the skin by venipuncture, it acts as a port of infection. Before you do the cannulation, we need to think whether this is going to be a difficult cannulation or it's going to be an easy cannulation. If it is a difficult, it's always better to get the help from a more experienced person rather than having multiple attempts for cannulation. And if the first person is unable to get the cannula after 2-3 attempts, always ask for help from more experienced or person for cannulation. Otherwise, we keep on doing cannulation 10 to 15 times, and the skin is damaged, and the baby will become septic in the next day. The other thing is after cannulation, with the cannulation, always we connect this IV extension set for all the babies. Using this extension set helps to keep the cannula for prolonged period, because this is how we connect this extension set for cannula. In our setup, we connect the infusions and antibiotics straight away to the cannula. We need to disconnect the infusions, and whenever we handle this part, there's a high chance of cannula is getting tissued. And if you use this extension set, usually we use the extension set with 2 ports, and 1 port we can use for IV infusion, the other port we can use for antibiotics and other infusions if we need. After cannulation, there's another score actually. This is to assess again the patency of the cannula and the evidence of infection. This score has to be assessed during each shift and documented in the monitoring chart. If there's any concern, the bedside nurse should alert the nursing coordinators and the medical staff. Next, I'm going to talk about pain management. Pain management in our setup is somewhat overlooked aspect in our neonatal care, but pain management is extremely important. One of the recent reports says the premature babies requiring NICU admission encounter about 14 painful procedures daily in the hospital. If you don't relieve the baby's this pain in the neonates, this can lead to immediate and long-lasting negative behavioral, psychological, and developmental effects. Therefore, it is extremely important to consider some kind of pain relief before painful procedures. So what are these painful procedures? These are the common painful procedures: heel pricks, venipuncture, lumbar puncture, peripheral arterial line insertion, IV cannulation, intubation, extubation, chest drain insertion, and central line insertion. Even gastric tube insertion is painful. Chest needling, IM injection, changing a dressing, and removing plasters, bladder catheterization. These are the common painful procedures, and these are all painful procedures. Therefore, we need to consider some kind of pain relief. So, what are the measures we can practice to minimize the pain? There are pain scores to assess the pain score, the severity of the pain. These pain scores are especially for babies who have undergone surgical procedures, which I'm not going to talk about much here. Before the painful procedure, there are so many other factors which can cause discomfort to the baby, like excessive lighting, tactile stimulation, and high temperature, loud noise. If you keep the incubator door open and talk loudly, and that can cause irritation to the baby, and they will be really uncomfortable. Even before the procedure, they start crying. And so before the pain procedure, whatever the procedure you are going to do, we should minimize these factors. Of course, you need good lighting, but still you can cover the babies with a soft cloth to prevent exposure to excessive light. Then we have non-pharmacological measures or behavioral measures and pharmacological measures for pain relief. Here I'm going to concentrate mainly on non-pharmacological measures. These are some of the measures which we can easily practice in our neonatal care. Breastfeeding is very easy practice, especially in the postnatal ward. Whenever we do heel prick sampling for blood sugar monitoring and blood sampling, we can practice, we can do ask mom to breastfeed the baby. And non-nutritive sucking is another practice we commonly use for pain relief. It really settles the baby when we use the dummy with some sucrose on it. Skin to skin care, cuddles or kangaroo care is another practice. Again, we can do when we do heel prick sampling, and this is a baby who is being ventilated having a cuddle with mom. Swaddling is another practice. As you can see here, that we can cover the baby once you decide on this side limb or lower limb, the place site where you are going to do the cannulation, and then wrap the baby like that. It really helps to settle the baby before the procedure, during the procedure. And the facilitated tucking and sucrose and dextrose, higher concentration of dextrose we can use for pain relief. Here we use 24% sucrose, but we don't have sucrose in Sri Lanka. What we have is 10% dextrose and 50% dextrose, and it is not practical to prepare this solutions before this procedure, whenever you do the procedures. But evidence, the research says that breast milk or 10% dextrose is a safe and effective method for pain relief during heel pricks in preterm neonates. So breast milk is the priority for pain relief. So therefore, we can use breast milk or 10%, at least 10% dextrose as a pain relief before you do any painful procedures. Medication safety, it is another aspect which we should improve. The problem in our setup is when it comes to medication safety, the less, as I think, the less responsibility we take during prescribing and delivering as doctors and nurses. And also we don't get involvement of the pharmacies much. In neonatal care, medication safety, here we have standard medication charts, and there's a monitoring system for all medication errors. This medication chart is easy to use, and it reduces a lot of medication errors. This chart has several 4 pages, and one section is for regular medication, and the another section for once only medication, and there's another section for PRN medication. Doctors should prescribe the medication here and write the date, medication in block letters, and route of administration, frequency, time of the day nurses should give the medication, indication, and then we should sign here and print the name. And here we have one extra nurse who do the medications during one extra nurse in each shift who do the medication. And every time they give medication to babies, they check the doses and the medication with the medication protocol with the bedside nurses. So two people check the medication every time they give medication to a baby. Therefore, the medication errors are very less. And in our setup, the problem is there is no system to monitor the medication errors, and we don't have medication protocols. We use PNF and this all medication book. It's time to consider formulating new medication protocols for neonates in our setup. And other thing is pharmacists. There is a pharmacist who do around every day, and they review all the medication charts to correct if there's any problems in the medication charts prescribing. Next, we need to think of formulating neonatal clinical guidelines. We do have guidelines which are not very extensive and not much updated. Here we have A to Z guidelines which made our life very easy, and these guidelines are accessible to everyone in the region, and it covers almost all during our neonatal practice. Next, I'm going to talk about the palliative care in neonatal practice. Palliative care is for babies like severe hypoxic ischemic encephalopathy and babies who are having congenital abnormality which cannot be corrected, and those who are having congenital heart disease, and babies who are critically ill with multi-organ failure. So the goal of this palliative care or end-of-life care is to ensure best care for the dying baby and their family. This includes supporting the family and caring for the baby. In our setup, the problem here is, as I think, our palliative care is in quite premature stage. In our setup, either mother or father or both are allowed to stay with the baby, and we have restricted the entry of other family members due to huge crowding, and there's no separate facility within the premises to provide palliative care. According to my opinion, it's really tragic for the parents to bear up this pain alone when they are about to lose their newborn baby. Therefore, we need to consider providing them extensive family support whenever possible. At least we should consider easing our policies to allow at least close family members to stay with the parents and dying baby. Care for the baby, we need to consider control of symptoms. We can consider giving morphine to relieve pain, and we can offer feeds as tolerated, and should optimize comfort care like mouth care, regular posture changing, and we can use soft music, pressure relieving mattresses we should consider using if available. And if the family wish to cuddle the baby, we again should support the family to follow the family's wish. And if the parents are happy, then we should allow them to take photographs with the baby and family. Research and quality improvement project is another aspect which we should improve. Here in this unit, the doctors, nurses, midwives, pharmacists, all are involved in some kind of quality improvement project or research, and that is why they are improving their every time. Even though they are doing their best, still they try to improve further with these quality improvement projects. In the neonatal unit, there are groups for these quality improvement projects. For example, here, as you can see, there's blood management team and communication medical team leader and nursing team leader, and there are other nurses are allocated to different teams to improve the quality of particular aspect in neonatal care, and their responsibility is to assess the practice and implement other practice and suggestions to improve the practice, and doing regular audit cycles to help to improve the neonatal care. Education programs. We have education programs, several education programs here. Neonatal resuscitation program, again, we have a neonatal resuscitation program. Here we need everyone who is involved in neonatal care should update their neonatal resuscitation certificate every 3 years, and there is a monitoring system to assess whether they have completed their program every 3 years. Apart from resuscitation program, there are various e-learning programs. These are some of the e-learning programs, online courses. But in our setup, we don't have a system, e-learning system. What we can do is, like neonatal resuscitation program, we can, for example, like airway management and IV access, cannula management, especially important, and thermoregulation, prevention of sepsis. So many, there are so many aspects which we can include in these learning packages. And there should be a monitoring system to assess whether everyone involved in the neonatal care, doctors, nurses, midwife, check whether they are completed these learning packages. Lastly, There are several fancy events to improve the cheer up parents who spend away from their newborn baby for prolonged period. And this is one such event, taking photographs with Santa during Christmas time. And this really helps to improve the parents' spirit and mind and reduce their stress and depressed mood. With that brings me to the end of this my talk. Thank you very much for listening.
Thank you very much, Sathika, for your informative lecture. It was comprehensive, but simply explained, and you have well elaborate, and your slides were self-explanatory. And you actually revealed the areas where we need to improve. And you gave good suggestions how we can improve it. And you gave, for example, the using extension sets. If you don't have the double lumen umbilical catheters, for that you can use the extension sets. I think it's more simple and it's cost effective as well. And in day-to-day practice, as you mentioned, the cannula, insertion cannula, which is very common practicing, I think we can minimize that handling by preserving the cannula after inserting. So, and the other areas are the drug errors. I think those are the things we actually less focus. So you elaborated those areas where we need to improve our. Someone, Kumar sir, wanted to say anything for Sathika's presentation?
Can you hear me?
Yes, sir, we can hear you.
Congratulations, Sathika. Thank you for that very comprehensive count on what you have observed and compared to what we do in Sri. And I have few questions as well as few comments. I'll start with your NeoRep. NeoRep and the NeoHelp. These are two different things, right?
Yes, sir, it's two different things.
The NeoHelp is the polythene kind of a polythene suit like thing, and the NeoWrap is just a like a wrap that you can plastic wrap, right?
Yes.
Okay. Okay. Because the two we are getting we are getting a fairly large amount of NeoWraps from Australia. I think it has almost reached Sri Lanka. I will be distributing to all the neonatal units, and more to come in the future. But actually, I was under the impression that NeoWrap and the NeoHelp is more or less same. But now I realize NeoWrap is just a wrap. But it is still useful. But I think for the management of new premature babies, rather than using plastic bags, ordinary plastic bags, the NeoHelp will be more useful. Isn't it? Sathika?
Yes, sir. This NeoWrap, the NeoWrap is a simple polythene sheet. Actually, we can use it to cover the baby when you do the procedures like cannulation. If you want to keep the door open, incubator door, or the hand ports open for prolonged period, then you can use the NeoWrap to cover the baby.
We can't use NeoWrap at the delivery room, yeah? Do we? Can we?
We use for babies more than 32 weeks of gestation. We use the plastic sheet to cover the baby, not the bag. Okay. Not the suit.
Okay. Because the NeoWrap is from New Zealand, NeoHelp is from UK. The prices are too different because, as you know, we are getting some donation from all over the world these days. I actually asked some people to send, so I'm getting only NeoWrap. So I think we should explore the ways of getting NeoHelp also to some, at least to use for premature babies. So that's number one. Number two, IV lines. How long do you keep the normal peripheral cannula after insertion? without any evidence of
Uh,
cannula site inflammation, or your score is still 0, how long do you keep it going without, when do you change it for a new cannula, peripheral cannula?
Maximum 3 days, sir. 72
So
hours.
after 3 days, even if the score is
3 days.
0, you change it to a new one, right?
Yes, yes.
Okay. And the CVL,
Sometimes if you think the next day you can grade up to full feed,
yeah, okay,
uh, then change.
just visible, yeah. And central line, how long do you use?
About 6 weeks.
Okay, the same line you use it for 6 weeks, right?
Yes.
Right. Okay. And about the pain relief, I think this is something that we do not consider to a great extent in our setup. But you mentioned you use sucrose and 24% dextrose, right?
And
Dextrose,
24% sucrose, sir.
sucrose, yes. And what about
Yes.
babies who are really sick and who are nil by mouth? What kind of pain relief do you use? Because when you can't use anything orally, what do you use? Do you use just morphine, or what do you do?
Uh, yes, we do assess the pain score,
Mhm.
and depending on the pain, first thing is morphine, and there are some ventilator issues or issues with blood pressure. Then we change to fentanyl, and yeah, basically it's morphine and fentanyl, sir.
Okay, good. And regarding the neonatal guideline that you showed us, the A to Z guideline, we have actually almost updated our guideline, but I'm still not happy with our local guideline, because it is very useful if we can have something online, as you mentioned. Is it possible to share this guideline with permission of the trust for us, where we can just see whether we can,
Yes, sir.
if you can share with us, then we can get together, maybe team of neonatologists from Sri Lanka, and we can edit it so that it fits to our setup, and we can make it for the whole country. So this is something that we can do, online neonatal guideline, but going parallel with the hard copy which is being done by the Ministry of Health. But I'm not happy with Ministry of Health guideline, but we can sit down and go through the Australian guideline, and we can adjust it to our setup and make it available online so that anybody can access it on the phone or on the computer. Is it possible to share with us, Sathika?
Yes, sir. I think even you can access the guidelines if you type the KEMH guidelines.
Okay, just if you can share with me the website or the
Sure.
access
Sure, sir.
link, then I will try that. And just a little comment about the uh, extensive family support when it comes to palliative care. What you mentioned is exactly right, 100%. That should be the case. But in our setup, as you know, it is not
Yes.
possible to get the extended family into the NICU for the family care. But I suggest, at least, I suggest all of you who have joined this forum, at least the father and the mother, at least father and the mother should be allowed to come and stay with the baby. And as you mentioned, to if they want to cuddle the baby, or if they want to keep the baby on the lap, or do kangaroo care when the baby is dying, and also to allow them to take pictures, footprints, and any religious activity if they want to do without disturbing other patients and the unit. All those things can be allowed, and we at Castle Street, we do allow these things if time permits, and I think others also should do, at least for the father and the mother, uh, because the rest of the family is a bit difficult. Uh, but my dream is to have a more kind of a private uh, rooms in NICUs, new development and the new state of the art NICU with more kind of a private rooms, to come, not even for the palliative care. Right from the beginning, the family can come and visit the mother and the baby, and that kind of setup that I'm thinking of. Then the last thing I would like, if you can comment on how the handing over and the giving over or taking over happening at the medical level as well as the nursing level. Because in our setup, handing over is not, I'm not very happy with the way that the handing overs are happening or taking overs are happening at the medical level, MO to MO, or the medical, within the medical staff. But I'm actually happy about nursing handing over, because you all can see they have a kind of a better way of handing over or taking over patients from shift to shift. But medical handing over is not very good. Can you just enlighten how it is happening, the handing over? I know when I was a trainee in the UK, we at the end of every shift we had a ward round with the consultant and with the taking over team, as well as the giving over team, and we do a ward round and we do a handing over. And every day in the morning, the night team has a morning meeting where we sit down and present all the patients and problems and do the handing over to the morning team. So what do you, Sathika?
The nursing handover and the medical handover happen separately. Nurses, they do separate handover. Nursing code, there's a nursing coordinator here, so nursing coordinator, and there's another nurse for medication. They do extensive handover, and the doctors, morning team, when the morning teams come, the consultant and the registrar, usually there's a consultant, registrar, and senior registrar come for the morning ward round, and then the night team hand over each and every patient at the bedside. That is how we do. And apart from that, we have a weekly grand rounds. The nurses, radiologists, and social care workers, pharmacists all get together and discuss regarding babies for about 2 hours, one and half hour to 2 hours. That is the kind of discussion.
Thank you, Sathika. Thank you. Are there any questions, Jitma, for Sathika in the chat box? I can't see any questions in the chat box.
Yes, sir. No other questions I also could see in.
Yeah, I think something that you mentioned gave a little insight to me about the quality improvement projects. This is something that we can think of. We have so many now, especially at Castle Street Hospital. We have so many trainees, and each one of the trainees, at least the trainees, can do little quality improvement project. So this is something that we can think of that will help the improvement of quality in the unit, as well as that can be taken to the rest of the units, as rest of the units in the country as well. So
Zaman, can I disturb you a little bit?
Yes.
Yeah, I know that I'll come back. Yeah.
Sorry, I got an alert coming in. That's all. Anaphylaxis. You're right.
You can go ahead. Yeah. You can
Sorry,
go ahead.
Samantha, can you hear me now?
Yeah, I can hear you. Yes.
Yes, regarding this QIP project, quality improvement project. I think I'm very happy to help any trainees who's interested in doing this quality improvement projects in the back home in Sri Lanka. One thing is, in this forum also we discuss about the family integrated care kind of thing. So I'm the leading in my trust now in the family integrated care. So I can integrate them with my teams as well. So they'll be more benefited for them to initiate that kind of quality improvement project in Sri Lanka. And they can continue when they come to Samma and they will see training as well.
Yes.
I think you or Deepal having my contact, so they can anytime they can contact.
Yeah, that's brilliant. Yes.
Yeah. The other important thing is regarding we discuss some the neo wrap or something, the plastic bag kind of thing. Is my personal views. We have maybe million products around the world. How useful it's. Recently we use the simple bubble wrap. It's very cheap. So that's worked very well. Thermoregulations with babies inside the incubator while we are doing the procedure. So we don't want it to go around and find out what the fancy stuff, spending a lot of monies and pumping the dollars out of the country. But the small measures will make a difference. So that kind of things I think we need to discuss in the back home, what the practice is doing, rather than the companies made whatever things. I know that the simple polythene bags replaced by in our trust with the Vigon products, which is very expensive. Here is maybe 20 pounds, so in back home it'll be some thousands. So it's maybe 10 rupees plastic bags, we can replace that. So I don't think there's any difference. We'll do all these two things, isn't it?
No, I think that's very correct. I have no idea of going for buying any of this fancy stuff for the moment. But I think personally, I also believe we are using the food grade, the wraps. You can take it from the what do you call what is this? There are food grade wraps. We are But they are we are using that, and in the private sector also we are using, and even at Castle.
Yeah, simply what's the McDonald's use for the keep the buns, keep warm, or Pizza Hut using.
We are using these wraps, and so that can do the same job. I think the Vigon, the Neo Help is very expensive, and so I actually, before this crisis, economical and the political crisis, I ordered all these endotracheal fixation and the pressure prevention, the gadgets and iPads and all sorts of fancy stuff. But I'm not going to follow up that, because I'm killing myself to find glucose strips, saline, and endotracheal tubes and all these basic stuff. So these new things, or the small items, are far below, down in my priority list. So we are struggling, as you know now. But simple things can make a difference, as what you mentioned, Sathika, is very useful, and they will be important. But for the time being, we have no money to think of these new things. But there are things that you can do without spending a single dollar. There are a lot of things that we can extract from your presentation without spending money. A lot of things. Once again, thank you very much for eye-opening presentation. Sathika.
Yes.
Thank you.
Thank you for everybody. I'm on duty, so I might go now.
Yeah, thank you, Priyanka. Thank you.
Sir, we have one question from Kanchana.
Yes.
She's asking, what about using the sepsis score in our clinical practice, whether we can use it or not?
We can definitely use it. Yeah. Although we are not using electronically, we are doing it similar calculation in our mind, and we assess the risk factors, and I don't know, I'm sure the people who work at Castle Street Hospital, we don't start antibiotics for each and every baby. even 28 weeker, 26 weeker, if there are no risk factors, and we assess the background and we do not give antibiotics. But as you know, in most of the places, whether there are risk factors or not, the babies are, I mean, antibiotics are thrown to all the babies, which is not good. A lot of places, many places. But we can use, definitely. There are a lot of electronic calculators online for sepsis risk factors, and so many things. So many things in neonatology. You can find a lot of apps, and we can. There are some of the apps are tested, and they are accepted widely on international platform to be used. We can use it.
In the absence of some other questions, I think we can conclude the session today. I will thank Dr. Sathika Amarasekara again for your informative lecture, and thank you very much for our participants. I can see about nearly 75 participants were there during this your clinical session. Thank you very much, Sathika, for your informative lecture.